So we are back in terms of the live stream. Thank you guys so much for staying with us. There have been people that have been here since 8:30 in the morning. This is our last panel, and it is a forward-looking panel. For those of you who are pretty familiar with the Peggy Lillis Foundation, our vision is a world where C. diff is rare, treatable, and survivable. And so we have a very forward-looking vision. And so one of the things that I was so committed to having happen with this particular summit was to have a forward-looking panel, because we get asked all the time by people who are suffering, by their loved ones, what's next to help me? What is coming down the pike? So we have assembled, I think, a really incredible panel of experts and people that are on the leading edge of this stuff. And so the first thing I want to do is invite them to introduce themselves and just talk a little bit about their background to sort of set the stage for the conversation. So for those people watching who don't know me, I'm Christian John Lillis. I'm the executive director of the Peggy Lillis Foundation, and I'm going to turn it over to Eve.
Hi, everybody, and good afternoon. Thanks for hanging in there for the day. And thank you to Christian. My name is Eve Humphreys. I'm the executive director of SHEA, which is the Society for Healthcare Epidemiology of America. And as was mentioned earlier, SHEA is really, our vision is safe healthcare for all. And so our real focus is on the prevention of healthcare-associated infections, the prevention of antibiotic resistance, and the promotion of the advancement of the field of healthcare epidemiology and antibiotic stewardship. And so we're really happy to be here. Just thank you for the invitation to you and to everyone at the Peggy Lillis Foundation.
My name's Olga Roniatis. Thank you so much for having me here today. I'm a gastroenterologist at Montefiore Medical Center. I spend about 50% of my time doing clinical work and 50% of my time doing research. I got interested in C. diff and became very passionate about studying C. diff when I saw my first fecal transplant in training with Larry Brandt. And I recognized then that we have a lot of work to do, and that there are exciting new innovative therapies that are available or that we can come up with in order to be able to provide our patients with exceptional treatment and get them feeling better. So most of my work has been in fecal transplant for recurrent C. diff and severe and complicated C. diff. I do these procedures pretty regularly at the hospital, and I'm also doing some microbiome work. We're interested in looking at some risk factors to be able to predict when patients might develop a recurrence, so that we can try to implement some therapies early on and prevent patients from getting to that second step from developing recurrence. Thank you.
And my name is Susan Watkins. I work for Sanofi Pasteur, and we're in the middle of a very large phase 3 trial for a vaccine to prevent C. diff. And so we're in 27 countries. We have over 8,000 volunteers in the trial, and we're hoping to get 8,000 more to show that this vaccine is not only safe, but also effective. And you're probably wondering, if you've had C. diff, why am I here? Because you've already had C. diff, so it's sort of too late. Since I've spoken to many of you who've, thank you very much, have given us some testimony on tape, I run into the same problem that Christian and the foundation does, is that there are a lot of people out there who've never heard of C. diff. And unless you've had it or know somebody who has had it, you don't want to talk about it, you don't want to hear about it. And so it's made this clinical trial very challenging. And so one of my jobs is to raise awareness of the disease.
Hello, my name's Niall Wallace. I'm co-founder, CEO of a company called Infonaut. I'm the Canadian on the panel. My journey with understanding infectious disease started with my experience in the SARS crisis, and then working with public health and hospitals to build tools to really understand how infections move through communities and move through hospitals. And we at the time thought the evidence base around that was very poor and that surveillance would help. More recently, as an entrepreneur and working in the United States, we've been frustrated with the pace of adoption of new technologies, solutions, and paths forward that can help prevent and control infectious diseases in hospitals. So with the not-for-profit journal, we formed the first center of excellence for infection prevention control in the world. Our goal is to scan the world, bring those innovations that we feel can make a difference to the United States, surround them with rapid validation and assessment, and help them launch into the market very quickly, because we firmly believe that innovation is really about commercialization. We can do all this stuff in the background with our lab coats on and invent things, but until we get things in the market, we're not really making a difference, and we're not improving patient safety or quality.
Excellent. So our first question is going to be another forward-looking one, which is from each of your individual or your sort of organization's perspective, what do you think is the next step we have to take in fighting C. diff and other HAIs?
I'll start. I think that's a really great question. I think, and having the benefit of the full day, I took a lot of notes today. I feel like that question is probably already answered, but what I wrote down was, I think, the key words that I heard today over and over was collaboration, that individually, any of our visions or our perspectives are not nearly as strong as what we could be together. And I think that that's really the only path forward, that traditionally we have been very narrow focused. I know that as a medical society, we tend to kind of be very narrow focused and focus on our members and what our members' needs are. And you know, SHEA is an organization that really focuses on public health and patient safety and healthcare delivery safety. And so we're able to, you know, we're very collaborative. And so I think that one of the areas that maybe we have missed and are recognizing is that there are other people we haven't invited to the table, including patient advocacy groups. And so, you know, I think just being open to new solutions, being open to new perspectives, not coming to the table with the answer, I think is really important. And I think that's really hard to do. But I think all groups that are interested in healthcare safety need to come without the answer already in their mind. The other thing that I heard, or at least that resonated with me, was there needs to be a lot more transparency in how and I'll speak on SHEA's perspective, how we're coming to these decisions and putting this guidance out and coming up with these education strategies. Transparency, I think, and inviting everybody to the table would help relay that transparency, I think.
So we also heard a lot about this today as well, but there's a prevention piece with C. diff, and there's certainly an innovation piece. So it's preventing the disease from happening, and then also having innovative solutions when it does happen. And I think, like my colleagues are saying here, that it really requires a very multidisciplinary approach. I'm a clinical researcher, but I can't do any C. diff work without the basic scientists, without the clinicians in the room, without the surgeons. It really, and obviously, without the patients and their perspective and what they're feeling and how we can improve their life and overall outcomes. And so it really does involve this very collaborative approach. We're appreciating all the microbiome data now, and we're learning a lot about it. But as we know, the microbiome can be affected by so many different things, not only C. diff. So rolling into this, nutritionists, the other drugs that patients are on, other factors that might be involved. So a very multidisciplinary approach in order to provide preventive and innovative therapies.
Well, I'm a journalist at heart, and so I think one of the problems is the media, especially in the United States, in that a lot of people don't know about Clostridium difficile is because the media doesn't use the term. They call it a hospital superbug. And so if you say something to somebody about C. diff, like in our clinical trials, and people are saying, I never heard of that, why should I care about that? In Canada, by the way, and the United Kingdom, and I think there's another country in Europe, but I forget which one it is. It's either Finland or Norway. The public is more than 50% at least aware of Clostridium difficile. And I think that's because the media isn't afraid to put C. diff in a headline or the lead sentence of a story, whereas if you read a story on C. diff in the United States, you have to pretty much get to the bottom of the story before you even see the Latin in italics. And, you know, maybe it's a matter of Americans just don't like Latin or whatever the case may be. But, you know, MRSA has an acronym. And you can call it CDI, Clostridium difficile infection, or whatever, but it's just not resonating. So, number one, I think one of the problems is actually the media. Number two, and I'm sure this is very close, as I know, to Christian's heart, is the reporting. And We've talked about reporting a lot today, and we're probably going to hear about it really more. But I think part of the problem with reporting, and I've worked for 3 hospitals, is that it's not a matter of pointing fingers. I mean, somebody mentioned the Medicare 1% reduction for certain hospitals or whatever the case may be, and if that's what it takes, so be it. But it really shouldn't necessarily have to be about pointing fingers, whether it's nursing homes or hospitals. If it's mandatory reporting, it's because we want to know what the numbers are. It's really about epidemiology. It's really not about embarrassing a hospital or whatever. The reason we're not doing clinical trials in nursing homes is because no nursing home wants to admit that they have a problem with C. diff. So those are my 2 biggies.
I'll be a little bit of fly in the ointment, but I think the good news is that we can only go up. And the bad news is I think the United States collectively, and I think there's some excellent work being done in certain areas, but it's collectively, it is behind the rest of the world in a number of areas. The basics, the understanding that a clean environment is the key to prevention as a first step. I don't believe that there's an economic imperative with hospitals currently to make extraordinary investments in infection prevention and control. And I think that responsibility really lies with the health payers and the governments to a degree. But there's all sorts of barriers for a hospital adopting more costs and gaining more knowledge about what's going on around infectious disease because of the liability and the profitability. And the third thing is you're very slow to adopt innovation because of a number of barriers in place. And until even the most simplest things, the United Kingdom has a campaign, nothing below the elbows. There is no shirts or anything, any lab jackets that have sleeves on them because these things are filthy. C. difficile does not grow on copper. Copper kills it, and there's very few copper surfaces in U.S. hospitals. And so some of these very basic things and understanding the patient hot zone and sort of cleaning around the patient, educating the patient on patient hand hygiene, very simple things are not happening until I think that there's an extraordinary investments that are starting to be made in these simple areas and getting more complicated. I think there's huge progress that can be made. The great thing that I see about the United States is when you turn your mind to something, it happens very rapidly. But I think there's a number of barriers in place to make that happen as quickly as we all want to see.
Yeah, so I think we can continue. I think we're going to go a little negative for a second, and then we're going to come back to more positive, which I think is, and I think Niall touched on this. But like, so for what you think in terms of what the next step needs to be, like, what are the obstacles that you're seeing? Like, you know, Eve, I suspect that you and I would have a slightly similar look at this, which is kind of like, you know, people don't necessarily want to collaborate, and people compete for funding, but I mean, so I would like for each of you to kind of address, like, what is the obstacle keeping us from the media, or, you know, so would each of you mind addressing that?
Yeah, so I would agree with what you just said. I think funding, resource allocation is a huge issue. I think that hospitals vary in how much they are able to spend on prevention efforts. And I think that's a huge issue. But we can't stay in that space. And so if that is the case, how do we empower people to make the case for more resources? Or how do we empower people to actually move beyond that and find other alternative ways to make their facility safer? And I think involving patients is another way to do that also. So, you know, we can't just kind of focus on, you know, lack of resources or workforce. Amanda mentioned workforce issues, that there's not enough practitioners in this area to meet this need that we're facing. And so the idea is we don't stop at those barriers, that we actually move forward, that we actually look to ways, novel ways, which is partnerships, which is collaboration, not just collaboration within the facility, but it's, so for example, for Shea, partnerships means partnerships with industry, partnerships with CDC, partnerships with other medical societies, people that maybe we haven't traditionally partnered with in the past, like patient groups, and in order to move past just that narrative of there's not enough money, there's never enough money, there's never enough money. You know, we really have to move past that, because we miss this opportunity to have that condition of participation for acute care, or at least for right now. That's not on the table right now, which is unfortunate for stewardship programs in acute care hospitals. I say it shorthand because I've been living it for 2 or 3 years, but it may be just not as shorthand as I think. I apologize. But maybe the regulatory levers are not in place. And so how can we move past that? We can't just stop and wait and for the funding or wait for. So really those partnerships, and SHEA is, we are a very small organization. We have a very small staff. We have a relatively small membership. And so partnerships are huge for us because we know that our voice is small, but together it's much larger.
Yep, so I agree with everything that's been said so far. I think some of the obstacles, certainly funding is an obstacle in order to get the research done and to put new innovative treatments out there. I think especially in this type of climate. And looking for novel funding resources is certainly another option to think about. But I think the only way to really get the funding nowadays is to build a team science approach and to really have these collaborative efforts, because it's very hard to study this complicated problem from one person's perspective, especially now with all the microbiome data that we have. There's such big data available that are out there, and it's hard to make sense of them, hard to analyze them. And so we really need bioinformatics people and the basic scientists and the clinicians and everybody to kind of collaboratively work together. So I think that's an obstacle. I also think the obstacle is going to be at the hospital level in just implementing various different therapies, as was said by Niall. But yeah.
Well, we have a different kind of obstacle, and the only obstacles I can speak to are with our clinical trial. Again, we're in phase 3, and we talked about comorbidities earlier, and somebody had mentioned that people over the age of 65 are the most likely to get C. diff. So most of you in this room are not typical, in case you didn't know that. So when you do a clinical trial, we want to go into the population that is most at risk. We're looking at people over the age of 50. We brought it down to 50, but most of the people tend to be a little bit older. And how do you tell somebody who's got chronic pulmonary disease, diabetes, kidney disease, or some other what we call comorbidity that we would like you to be in a clinical trial for, again, something they never heard of, Clostridium difficile, and they're dealing with all these other issues. So could you imagine, that's what's so challenging about it, because again, people haven't heard about it, and we're talking about a sick population. Usually for a preventative vaccine, we deal with healthy people. Even if they are elderly for flu, they don't have other issues going on at the same time. So we're talking about people who are what we call frequent flyers in the hospital, take antibiotics on a regular basis, are going to have some surgery, maybe their gallbladder or some joint operation. And do they want to deal with being in a clinical trial? Probably not. So it's a lot more difficult for us. Those are our challenges. But what will the challenge be when hopefully this is successful, this trial, and hopefully the US FDA, which has given us fast track status, which is a good sign because there's an unmet medical need. But what would the challenges be going to market is, I don't know if it was Tom or who said earlier about it's hard when there's some new intervention or to get people to change their ways. And I'm talking about healthcare providers here, if you don't mind for a second. I'm not talking about the general population. But I mean, I don't want to speak for Merck, but the shingles vaccine I kind of watched, which made perfect sense that once you're over the age of 60, because that's when insurance pays for it, you want to get the shingles vaccine, because if you had chickenpox, this virus is living inside of you, and when your immune system is a little bit more compromised, it could come out as shingles. That seems like a real easy sell, doesn't it? Well, for some reason or another, physicians are fine with giving young babies vaccines, and they don't have to offer a flu vaccine. A lot of elderly people call their doctor and say, "Do you have the flu vaccine yet?" But flu, the average death rate for flu in the United States is only 10, I shouldn't say only, it's 10,000 a year. This has a higher death rate than even flu. Now the flu seasons change, every year, depending on the flu strains that are circulating or how effective the flu vaccine is, and that's another story. But C. diff is a serious problem, but I'll be willing to bet dinner anywhere in New York City that when we get to a point where we can license this vaccine, we're going to have to go to the general public and say, you need to ask your doctor for this vaccine, if you're over the age of whatever.
What was the question again? Challenges?
So
I think I jumped all over the challenges before, so maybe I should offer a little bit of hope. So the economic challenge is there, but the sense that I get from a population health perspective, if we work with health payers and we give them a way of seeing that should someone acquire C. diff and they survive their hospital stay for the next 5 years, that's a very expensive proposition to cover that person and insure that person. So we've laid out sort of the economic argument for the insurers, and it's one thing to understand is the financial aspect. So bringing the insurers along with the innovators, the researchers, and the hospitals to collaborate on this, because I don't think the economic incentive is going to be picked up by the hospital. They're just not going to run with the extraordinary measures that need to be taken place to save the money over the longer period of time. The other thing is I think innovation is fun, especially innovation in healthcare. We've got a very caring population dedicated to taking care of people. I can't think of a hospital that wouldn't have a group of people, should they realize that C. difficile was a problem, wouldn't want a working group around fecal transfers or start to adopt new technologies in that area that are simple to do, that have been proven to be effective in the stages that they're in, and show that they save a lot of money and develop better outcomes as well. And the third thing is that when you have a dedicated group of people together in a hospital and you get them collaborating, they really take that comprehensive view of looking at the environment, looking at the treatments, looking at the drugs, you get a very different effect on the culture. And for the longer term, to get improvement in a hospital that is sustainable, you really have to have better attitudes towards the risks they're taking, a real in-depth look at the behavior that's driven by evidence and science, which will result in a better culture. And I think that's the only way to predict that these systems are going to get better going forward and that patients are going to be in a safer environment. This also makes workers very sick. If you are a healthcare worker, you are 1.5 times more likely to be absent from work due to gastrointestinal or influenza. If you are a dedicated care worker and you care about yourself, and you care about your family is more so than the patients, you want to get involved in this because you're protecting yourself as well as making a better environment.
Thank you. He speaks with such confidence. I like it. That's like me too. And then I'm like, oh, okay. So we have a number of patient advocates in this room, many, many more watching. Again, largely people that have had the disease or have loved ones. And I think, the point that Susan brought up earlier is that the people that are here tend to be people who are younger, who are caregivers who have lost an older, grown adult children of people who have been lost to the disease, like me and my brother are. So it is a sort of atypical formulation, but I think that what many of us would like to know, and I think Catherine spoke so passionately to it earlier, is like, what does it take to get a fecal transplant to be given earlier? What is it, there's different aspects of it. So I think my question would be, and I respect also that Shay's kind of just exploring this, so don't feel too pressured, but what could patient advocates, how do you even envision patient advocates working with or increasing their work with the various constituencies that you represent to kind of spur us to that future?
So I think that's a really important question because, medical societies tend to be kind of very limited and very methodical about how we develop guidance and how we develop clinical practice guidelines. And one was mentioned earlier that Shay is involved with, and how some of these more novel approaches, it's really difficult to get those incorporated into these clinical practice guidelines because the research is not there. Mm-hmm. These are evidence-based guidelines. The research is not there, so there is no evidence to base the guidelines on. Absence of that, I think that one of the things that Shay is trying to do, and I can only speak for Shay, is there is expert opinion. So we have clinical practice guidelines, which are evidence-based, and we have expert opinion, which Shay members have. We have developed a process to write expert guidance. So this is not evidence-based guidance. We have one on healthcare worker attire. You talked about the bare below the elbows. It wasn't a clinical practice guideline. It wasn't evidence-based, but it was expert opinion. And so we have not used that method or that structure in C. diff, in novel treatments, and in a lot of what we've been talking about. But so we have tried to, at least with Shay, tried to develop some kind of structure that we could get expert guidance published outside, even if there's not evidence, to support a full clinical practice guideline. And then do all we can to really get the evidence out there, to really fund the research, or at least help raise funds for research, and that will fill this gap, because I think that's what's missing is the evidence. I don't know if that answered your question, but that's been what I was thinking about. I didn't want to let the comment go by earlier, because it's very frustrating. We find it frustrating that we can't, that it's which is one of the reasons we wanted to get another avenue for expert guidance out there quicker and, absent evidence.
And so just let me drill down on that for just one second, Eve, and I might do this with each of you, but do you envision the role then of sort of the patient advocate or the caregiver to be kind of like making sure that the prevention and public health fund stays there, or making sure that there's expended NIH funding for, fecal transplant? Like is that what you're kind of envisioning? Because I think that is where a true partnership could occur. And I think to give a little history, like last year when the FY16 federal budget was happening, like there was a question mark, was there going to be increases for some of these things? And a lot of us in coalition worked together and made that happen.
Yep.
And that included, I think, actually me, I think, and Lynn. I think we went to OMB together, didn't we? Was that you? Oh, no. it was me and somebody else. It was Jonathan Nurse from IDSA. We went to OMB together, and they were asking us, like, if this money doesn't get through, like, what the money is there, like, how should that be spent? And I was like, well, let me tell you how I think it's... But, I mean, is that what you're kind of thinking?
That is what I was thinking, and thank you for... remind me to bring it back to actually your question. So I think the advocacy partnership is incredibly important. And when Lynn and I were talking last week about coming and what really do we want to be talking about, it is that our messages, if we're talking on behalf of the healthcare provider, you're talking on behalf of the patient, and we're sitting next to each other and we're talking to a congressman, that is so much more powerful than me sitting by myself, or you sitting by yourself. It's a really that kind of approach. But so that advocacy piece is important, but also a patient voice on that expert guidance development, I think, would be incredibly valuable, because if we're talking about implementation guidance and things like that, I know that that's being talked about, and so that having that voice on even when some of these things are being developed, these expert opinions.
Thanks. Olga, same question. Like, what do you think in terms of how can patient advocates help you and other clinical researchers?
Yeah, so I think we've wanted to do this at Montefiore for a long time, really doing a fecal transplant after initial bout of C. diff, or maybe in a high-risk patient group, because I think part of the issue is, which we discussed actually the other day, and it comes up all the time, is what are the long-term consequences of a fecal transplant? And we don't know them yet, and those we won't know for 20 years down the road. And so it becomes this risk-benefit ratio. And so if you can sort of identify a high-risk group for recurrence after their initial infection, then maybe you can make an argument that those are the patients that you want to do a fecal transplant in, because the potential long-term risk may, the risk of them having a recurrence might outweigh the risk of potential side effects of a fecal transplant. So I think in certain ways, we would do this if we had the right support behind us to make it happen.
Mm-hmm.
So again, if we have the patient advocates and the group supporting us to pursue such an endeavor, then I think that this could be a really exciting thing to have us do. So having the patients around, the funding there, the scientists there, everything kind of in the same realm in order to make such an endeavor happen.
Yeah, I mean, so my sense, and I'm going to try to reframe this and see if you agree with me, but I almost think what Chuck touched on earlier, and again, one of my reference points is always LGBT rights and HIV/AIDS advocacy, because that's where I first got started. But almost in terms of like what ACT UP was able to do, in terms of telling the FDA, we want the right to get this earlier, and we will take the informed consent because that's kind of, that's how I feel about fecal transplant. Is like, I don't think it's an ideal situation, but I feel like if it's that or death or being debilitated for months on end, maybe I want to roll the dice. And I feel like that's also my right.
Absolutely. And I think the thing that holds up physicians are really what the FDA guidelines are. So we're not legally supposed to do it in a patient who has an initial bout of C. diff. But if there was some understanding between the FDA and the patient population that this was something that if the patient really wanted, understood the risks, was consented properly, appropriately knew their rights, then we could pursue that. That would be extraordinarily helpful for physicians, and I wouldn't be opposed to doing it in those kinds of situations.
Susan, same question. How can we work together a lot, so I might know the answer, but
and of course I can't speak to fecal transplants, but I can tell you how we like to work with patient advocates in vaccine developing and manufacturing. And I had already mentioned that it's hard to get people who are already a little bit sick into clinical trials, so your testimonies really help us to put a face on the disease. But I can tell you, since the folks from the CDC left already, is when we go down to the CDC after we develop a new vaccine, and US FDA licenses it, they determine the indication, and that is strongly based on our clinical trials, but it's the CDC that recommends it. And I would imagine physicians look for that, especially pediatricians and other physicians, primary care physicians, who are pretty much the ones who give vaccines. We love to go down again with putting a face on the disease, because we could sit there all in suits in this big meeting down in Atlanta, and there's a gazillion of them and there's a gazillion of us, and we get up and give our testimony. But when somebody stands up, we did this with meningitis for adolescents, and they tell the story of losing a young child or a loved one to this disease, there's nothing better.
I don't think it's a democracy, and I think that the most important voice at the table belongs with the patient advocates. So I've been to the last 3 conferences in the United Kingdom, the NHS conference where everybody comes to talk about infection prevention control. And the moderator and leader of the day is a representative from the MRSA Society, the National MRSA Society, the National Sepsis Society. Can we imagine if Christian ran the APIC conference and you were there at the front?
I don't think APIC would like that.
Well, I mean, it's really giving a voice to sort of the most important people in the ecosystem, and that is the patient, especially when we're in an age where we have to make extraordinary efforts because the consequences 10, 15 years down the road are so serious. And I really applaud the way that the UK has approached the problem. They've made, it's not a great system, but they've made massive strides. They implemented 4 big changes very recently based on really the input from patients and patient advocates were a key driver. They withheld 2.5% of a hospital's budget on an annual basis, and they can reclaim that if they make investments in innovation around infection prevention control, except for a couple of other areas. The head of IPAC can recommend to the government that the CEO and CFO be fired. It's not going to be done, but they can recommend that that be done if those investments aren't being made. They withhold, I think it's about £100,000 a day to poor performing hospitals on a ranking related to, and C. diff is certainly in there, which is why they've made some changes there. And the final thing is they have opened it up for patients to, I don't think sue, but get compensation from the hospital systems if they acquire, and it's proven that they acquire an infection in the hospital. So 4 extraordinary moves, and it has really tried to change the way and change the culture that they're dealing with infections in Britain. And we're seeing a lot of innovations that we're actually trying to bring to America. Really simple things like antimicrobial pillows and sheets and cleaner patient areas, less harmful chemicals, a focus on the biofilms and cleaning processes. These are all things that came out of the UK system in a very short period of time because they put that type of effort on it and made the consequences serious enough that people were paying attention.
And so to drill down on that, I mean, in terms of the patient advocate role, is it that people demanded it? Did they go to their MPs in Britain and say, like, I'm sick of the fact that our hospitals are getting people sick?
Yeah, absolutely. I mean, the head of the MRSA group, Derek Butler, in particular, is a real bulldog, and he made the relationships at the national level in the UK, and really was one of the people that insisted on change. and he had a real groundswell of support behind him. And, you know, a number of strategies to get there, but I think because the problem became so acute and so many people were affected by it, and it was in the media much more perhaps than it is here, you really had that groundswell behind them, which allowed them to raise funds, allowed them to be in the face of the representatives, and really drove the consciousness of it to an elevated level within the government and the public consciousness. And that just, it meant that change had to happen because the situation was particularly poor.
Thank you. So we have a few minutes left. I think we're going to open it up to questions from the audience. Catherine, I think, has a question.
How can I raise awareness of C. diff to adults with intellectual disabilities without terrifying them?
I think let the clinical person take this one.
I can take a stab. I mean, I think that's a very difficult question. I think, you know, certainly maybe discussing some of the signs would be important without going necessarily into extraordinary detail. Just understanding what might be a clinical sign that I need to be aware of. So the 2 or 3 main things. So, you know, diarrhea, and diarrhea can be explained in many, many different ways. And it might take a few different iterations of how you're actually going to describe that to a patient. But diarrhea or fever or abdominal pain, and just having it sort of on their radar as like, these are signs, these are things that you know you need to be aware of for yourself and maybe for the community that you live in as well. I think I don't know if that answers your question or if it's more of just raising awareness on globally on how, you know, just that C. diff exists, or more along the signs and symptoms and how it might impact their life in general, or the life of their loved ones.
Or maybe the antibiotic stewardship piece, without calling it stewardship, but I think it was Gerard who had a slide this morning that showed the normal gut. And, you know, it's the good bacteria, bad bacteria story that I think a lot of even young people will get, you know, if you turn it into a game. Everybody's got good bacteria, and not all bacteria is bad. And when you take antibiotics, the good bacteria goes away, and the bad bacteria takes over. So, you know, you want to be careful, and you're not taking antibiotics for a cold or unnecessarily, you know, that kind of thing. You know, so maybe the good, bad thing.
I might add to that.
Yeah.
So much of this is put yourself in the person's shoes so that you can deliver the message. You know what I mean? It's so important that we don't come with our own perspective. If we're trying to answer a very scary question, to come from the perspective, you know, just try to imagine what they're feeling, and then I think the message probably comes out a little better.
Yeah, and I think Sarah and Chuck had a question, but I would just briefly say that we get a lot of messages and a lot of emails from people who have either had C. diff or their loved one in a nursing home has C. diff, and you know, there is that fear factor that takes over where they're like, I'm going to give it to my kids. I'm going to get, you know, we had somebody earlier today say, like, when they had it, they were visiting their mother in the nursing home, and like, did I give it to her? You know, and I think so part of it is also being cognizant of the fact that, like, as Gerard said this morning, like, it's kind of a 1-2 punch to get C. diff infection. Like, you have to be exposed and have so it's not just like, oh, I was in a hospital where there was a C. diff outbreak. Like, there are many people who can be in that situation and be fine. So I think we need an awareness, because the lack of awareness is killing people, but it's really just more that if they knew the signs, they would seek treatment earlier. You know, that is really the issue here, is that people don't act quickly enough. Sarah, did you have a question?
I wondered if you at Montefiore, if you know of another group, are you keeping a registry of everyone who gets a fecal transplant? Because that would be a way to work with the FDA.
We do.
You know, we're following these people. We will be able to keep track of them periodically for 20 years. And
yeah, we do actually have a list of everyone we've done a fecal transplant in, and we use standard donor material, actually. So it's very well logged and detailed, and we follow those patients up at specified intervals over time. So we have that, but it's a slow-growing sort of thing. I mean, now, I end up getting a lot of transfers from outside institutions for severe complicated C. diff, and I'm following those patients very, very closely, since that's a whole other issue to deal with. But yes, we have a registry, and eventually we will be able to hopefully use those data to speak with the FDA.
Is that something that should be expanded? Like
so
to include,
there is a national,
your group.
So there's a national,
or Catherine's group.
There is a national registry now that's NIH funded. So we're part of this national registry, and you can become part of the national registry as well if you're a clinician who does a lot of these fecal transplants. So that is something that's happening. It's just they're still collecting data. This is it's a new endeavor.
I think Chuck had a question, and then Dr. Brand had a question.
Yeah, my question was for Niles about how much can insurance companies be a force for progressive change on this issue, and do they really get it, or some do, some don't? What's your assessment of where they're at with the issue?
That's a great question. So the way that we approached it is we actually built the financial model for them. We said if you can isolate amongst your cohort of patients those who may have acquired an infection in a hospital, and just take a look at the next 5 years, look at their primary care, RX, home, therapy, rehab, put all that together. And the one thing that the insurance companies understand is their per member per month costs. What is this cohort costing us versus what they pay in? And that's an eye-opener for them, and I don't think they've ever taken that perspective. The second challenge with them is they do realize that it's a challenge, and what they're having trouble doing is incenting hospitals to do the right behavior. And so they have started to give them financial benefits or awards to adopt things like better hand hygiene. But unfortunately, some of the measures around hand hygiene, unless you've employed a system like Paul's, where we've got electronic measurement, we've got accuracy, if you're taking an auditor's results who's standing there 20 minutes a month and doesn't see everything behind the curtain, is scoring people at 95% hand hygiene accuracy, that's the type of the data and the nonsense that just, it's not making the situations better. It's just an easy way to sort of score some things and get some money from the insurance company. So part of it is, I think, the insurer, the hospital, and the innovation vendor sitting around a table displaying what is new and what is possible in this world that we can do today, and how to get and grab real evidence that these things are being successfully adopted and the trends are going up. The one thing that nobody buys is if you're going in and you're selling a system that is going to have we're going to reduce infections 20%, at $10,000 average cost, you're going to save $2 million, blah, blah, blah. Nobody buys that. So the ROI really has to be built around what are the real savings that are going to be felt by the hospital, by the insurer over a longer period of time, and what I believe is how can the innovator participate in that discussion so that we are adopting these new solutions faster.
I'll just build on that and stay with you. I've worked a lot with large employers, sort of Fortune 200, on their benefit design things, and they often listen to presentations around more innovative things to consider being leaders even faster than the insurers on covering things. It seems like a great thing to put in front of those employers if you haven't already, and I can help with that, because absenteeism and productivity and things are so directly affected by this condition that the return on investment is not just what the insurer's return would be, but the actual employee cost or lost work. So I would love to help with that business case.
No, absolutely. So I would say that if you've got a forward-thinking company that's got a good wellness program, they're paying for gym memberships. They're putting new applications in place that are going to help you track your food and intake and your calories better. The Fitbits and all these things coming out. They will make investments in their population that they have sort of, control and coverage for, because they realize that in the longer game, this is really what's going to save them money. And I think that the opportunity, and I was talking about it with some colleagues earlier on, is that because more and more of your health care systems are actually resembling single-payer systems. You got the insurer that owns the healthcare system, and they want to keep people out of hospital because they can't afford to keep treating people in hospital. Then you can make the case for it all working. I think it's really going to be driven by the payer, though. but in such a way that everybody kind of comes to the table and it's not punitive, that they feel that they're actually working from a baseline and just working there to get things better.
So we have time for one more question.
I'll ask it. Who is the payer?
Well, in Canada, it's pretty simple. You know, the payer is, well, you know, the U.S. is a really complicated system. I mean, you can imagine, you know, me landing from outer space and trying to understand how your system works. CMS covers 55 to 60% of your population. You do have single payer in many respects, and the Blue Crosses and the other health payers of the world, United, they take all their cues from what decisions the governments are making because they are the majority in the market. The CMS penalties that came in 2008 were then subsequently adopted by the other health payers because they're really taking their lead from the government. So, listen, it's a complicated situation. Your politics is a little crazy, but the government does play a leadership role because of the level of coverage they do provide and their intrinsic interest in better population health.
Yeah, and I mean, the thing that I would add to that, even though you didn't ask it, is that, you know, we get very obsessed with saving money, especially in government, and sometimes we can save money in the wrong ways. So one of the great things about Medicare and Medicaid is that it has a administration cost of 3%, which is far lower than any private health insurer. Now the question mark there is, when you have, you know, some fraud issues or people don't have access to be able to talk, you know, contact somebody at CMS to help them, maybe we need to spend 5% to actually make the system work a lot better. And I think you can, you know, so sometimes it depends on, like, you know, it's sort of the ounce of prevention is worth a pound of cure. And I think the payers respond to that because if we prevent a C. diff case for a hospitalized patient, well, that insurer is paying $8,000. If we get you a C. diff case, then you're tripling your cost for that insurer. And particularly when it comes to Medicare and Medicaid being 55 to 60% of the market, you know, that amount of money, you know, that money is actually money that we're paying as taxpayers, which I have no problem paying for a sick person to be treated. You know, I'm not engaging in generational warfare. Like, I'm fine with paying for Medicare and Medicaid, but I'd rather that $24,000 help 3 people and not be used for a preventable infection. I mean, that's my 2 cents on it. And I think, as they say in cable news, we're gonna have to leave it there. I think I should be a cable news host, just like, we can leave it there. So thank you guys so much for being an awesome panel. Thanks for having us. So, I'm just going to ask my brother to come up here for a quick second. You know, I don't want to get too weepy about it, but, you know, it really was just last Friday that it was 7 years since we lost our mother. And, you know, there are people in this room who knew her, not many people, but people in the room who knew her. And she was such an amazing person. And for us, you know, doing this work, is a privilege, it's an honor, it's hard. You know, we often have to revisit very painful things. But to have this room, you know, I think we had 40 people at our first summit, I think we've had 60, and then with the live stream, from what I can tell, over like 1,200 people have at some point watched the live stream this afternoon. And somebody said to me last night, actually I'll give him credit, it was Jason Newland, we were talking about the field, and he said, well, when I think C. diff and patient advocacy, I think Peggy Lillis. And so, you know, we are, and many people expressed to us just the caliber of people that came here to be speakers, the distance with which survivors and caregivers travel to be part of this. As I said this morning, amazing things came out of our first summit, and I think that even more amazing things are going to come out of this one in a very different landscape, but I think in a very, very powerfully.
So I'll shut Christian up by taking the mic. So what I'll just say is I'm grateful for everybody that came out today to help us, you know, with the Peggy Lillis Foundation. And if I know my mother would be okay with giving up her life if she saved a bunch of other people, and that's the truth. That's who she was. She was a great person, and she'd be proud of what my brother does and what everybody else does to help us out every day. Thank you, guys.
Thank you guys so much.